Hotbed Talk.
I'm really excited to be one of the co-chairs for this next session, where we are going to be looking at the impact of perioperative interventions on postoperative pulmonary complications. We know pulmonary complications are a significant source of morbidity, mortality and increased costs. And it gives me great pleasure to introduce my co-host, Mark Hamilton. Mark, welcome. Many of you may recognise Mark, who was one of the founding chairs of the EBPOM meeting. I think it's 24 meetings ago now. He's taken up a post recently in Plymouth as a medical director, so leading one of the largest NHS trusts in the UK. So has moved from being a critical care clinician and anaesthetist to someone leading the challenges of running a large tertiary trust during COVID, which I'm sure could be the subject of a full talk on another day. Welcome, Mark.
Morning, Denny. Thank you. It's fantastic to be here. As you can see, I'm sitting in my kitchen today, so I've escaped the hospital for a couple of hours to come and watch EBPOM, and it's just fantastic to be back. As you say, we've got a great lineup of speakers. I'm looking forward to some good debate this morning.
Excellent. So our first speaker this morning is Linda Denehy. And so Linda is a professor of physiotherapy at Melbourne University in Australia. And she's also head of the health sciences faculty there, looking after all of the allied health professionals. And Linda is a very experienced physiotherapist who's had a long track record in research in both rehabilitation studies and more recently in prehabilitation studies. And she was one of the lead investigators for the LipSmack randomized controlled trial. And we're going to have a chat now, Linda, about prehabilitation and respiratory prehabilitation and how what we do preoperatively can impact patient outcomes after surgery. So welcome. I think the first thing I'd like to ask, Linda, having seen your presentation, is what exactly does physio-led respiratory prehabilitation involve?
Yeah, that's been a question that I've been asked before, Denny. It's really great to be here, so thank you for the invitation. What do physios do? Well, we've been doing it for a long time, actually. So we used to call it pre-op physio. And, I've been doing that since the 80s. But with the onset of same-day admissions, physios don't tend to do pre-op, certainly in Australia, they may in the UK, anymore because of costs and workflow, really. To have a physio sit in the pre-ad clinic all day is not a good use of resources. So we used to do a lot, but now only up to 50% of hospitals in Australia actually use preoperative physio. I'm hoping that might change with the research, the emerging research that's coming through and is still coming through. So what we do is we educate patients and try and improve their self-efficacy. So through the education in what's really a teachable moment for patients having major stressful surgery. So education about what happens to their lungs. They usually say, a physio? I don't need a physio. I haven't got anything wrong with my back or my neck or my muscles. And you say, well, no, I'm not really here for that. I'm here about your lungs. And they go, oh, really? So I've spent a lot of my life saying that to patients. So we teach them about the surgical process, the stresses of surgery, what happens to their lungs, anaesthesia, and then what happens when they wake up and the risks for them of atelectasis and then that going on to hypoxemia and a post-op pulmonary complication. So the first bit's education, and then it's to teach them breathing exercises. So the standard physio is to teach deep breathing exercises. Sometimes physios call that ACBT, which is the active cycle of breathing techniques. So breathing exercises, supported cough. So we teach them, pretend you've got an incision in your abdomen or a whole lot of little portholes these days, and put a pillow over your tummy so you can have a more effective cough. And we talk to them about getting up, sitting upright so that you're improving lung volumes by sitting upright and getting out of bed and ambulating early with the nurse or the physio. So that in a nutshell, that's sort of standard pre-op physio. And it's the same in the UK.
People often ask about incentive spirometry. Could you comment on the use of incentive spirometry preoperatively? And is there any evidence that is better or less effective than the other types of breathing exercise you've just alluded to, so the deep breathing and the ACBT?
Very good question. It's a bit of a controversial topic because a lot of people around the world do use incentive spirometry, and in other states of Australia it's quite highly used as well. In Victoria we don't use it very much. The evidence suggests that there's not a lot of evidence that's actually looked at the components of the different sort of aspects of pre-op, and that's the same a bit in prehab really. So, it's looked at it as a package of care. So for the breathing exercises, there's not a lot of evidence specifically to say that one is better than another. The most evidence now is probably negative for incentive spirometry. So initially it was, well, they're all just as good as each other. But there's been some specific studies in incentive spirometry just to suggest it's actually no different to just asking a patient to deep breathe. And the other area that you might be asking me about is inspiratory muscle training, and that also has had some, specific component evidence.
Excellent. So I've just had it from Slido where someone's just asked really what IMT is, and is it the same as incentive spirometry? And that's actually an area of quite a lot of confusion. So it'd be helpful if you could explain the difference between the two, Linda, because there is more evidence, as you covered in your talk. There's it's all single centre small trials, but there is evidence that IMT, inspiratory muscle training, may reduce post-op pulmonary complications by as much as 40%. But as you say, there's actually evidence with incentive spirometry that it doesn't do that, and yet we seem to persist in doing more incentive spirometry than IMT. So could you explain the difference between the two so that everybody's clear about that?
Yeah, you're quite right. There's some good evidence for IMT. So we separate them out by calling IMT loaded deep breathing exercises, whereas incentive spirometry and just standard deep breathing and ACBT are unloaded. So when you're using an incentive spirometer, there's no resistance in there. Whereas when you're using an inspiratory muscle trainer, which is just a mouthpiece with a valve, like a PEEP valve, you just screw up the PEEP valve. This is a threshold device and not one of those new high-fangled digital ones. They're cheap. You just screw that up to put a resistance on, and you base your treatment on the patient's maximal inspiratory pressure that you measure. So you actually have a resistance to inspiration, but you don't in incentive spirometry, nor do you in standard deep breathing exercises.
Yeah. So I think that's a really important point. Just like any form of exercise training, you need to tailor the strain to the patient. So we do that by measuring their strength at baseline, and then you need to progress their training. So once they start to find it easier, you have to make it harder for them, or they don't continue to improve. And so inspiratory muscle training, as you just said, it's a bit like breathing through a straw or a narrow straw, and you make the straw narrower and narrower. They suck in, don't flow out. Is that reasonable to say?
Yep. Yeah. It's the resistance is on inspiration. And it's an exercise, just like exercising quads. You have to think about frequency, intensity, and progression of exercise. But that's not the case with incentive spirometry.
There's another good question on the Slido about, do you think you need a physio to deliver this education and training in breathing exercises? And does it need to be face-to-face? Or with all the changes with COVID and online meetings, could it be done either via a virtual environment, or indeed, does it need to be somebody who's highly trained as a physio, or would somebody else be able to deliver that information who isn't a physiotherapist? What's your feeling about that? Is there something specific that you're able to do?
So two things there. To answer the second one, really, yes, it can be done over telehealth, providing you've got video conferencing. Can't be done over the phone. It's really easy to teach and it's really easy to use. So it's easy for the patients in general, and we have used it over telehealth, and we've done a lot more over telehealth, as you say, because of COVID. If a physio trains someone else to do it, yes. So our exercise physiologists use it. Nurses could use it. We haven't tried that. There's been... So the only evidence where nurses have done some pre-operative respiratory didn't actually yield positive results. So there's obviously something in the training that's important. So I think you can train people to do it if you can train the patient to do it, you should be able to train a health professional to do it, really. But it isn't difficult to train the patient, and yes, with video conferencing.
And do you think the training pre-operatively is an important part? Can you just tell patients about this immediately after the operation? Why do you think the pre-operative element's important?
Couple of reasons. First of all, well, we all know what patients are like immediately post-op. They're pretty drowsy and not really with it, and often feel a bit nauseated and don't really want to do much for you. And the other reason is that what we know is that if we actually teach the patient and really stimulate their self-efficacy and have them practice, they're in a really good place to actually start doing that straight away. And the reason that's important is that the timing of PPC, the post-op pulmonary complications, is important. It happens within the first 3 days, and indeed most of them happen by day 2. So depending on the time of surgery, by the time anyone gets to see the patient, you're almost at the end of day 1, early day 2, and it's probably too late. You've missed your window of opportunity. But if you teach the patient really well pre-operatively, you get them organised to practice. Tell them every time the nurse comes in to change something, they have to do their deep breathing. That's the really important part. So I believe that teaching pre-op is the way to go. That's why I'm hoping that more physios, more hospitals actually reinstitute pre-operative respiratory management for patients.
Another good question, could that be incorporated into something such as a surgery school, along with other education for the patients, as part of the whole sort of enhanced recovery pathway, encouraging early mobilisation? Because there's a huge amount of overlap, isn't there, in the expectation management, telling patients what to expect, pain relief, the importance of getting out of bed. Do you think that might be a good way to get this information to patients?
Yeah, I'm certainly a believer that multidisciplinary, multimodal is better than just having a physio, especially for patients who have surgery for cancer, because I think they have many other issues happening that they need to know about, especially nutrition, for example, psychological issues around depression, anxiety. And as you say, there's a lot of overlap with pain management. So I think surgery school is a really fantastic concept. And part of that is the respiratory management, the early ambulation as well, and also the importance of physical activity for after surgery. We've actually just been doing some work with surgery school remotely, so using webinars. The first 35 patients we've published about the feasibility of using it with surgery school, using videos and a live host. And we're continuing to collect data to have a look at the efficacy of that. And so we've done nearly 100 patients at Peter Mac on surgery school remotely, but just observational. So there's not a lot of research. There's a lot of pre-post studies around surgery school, but there's not a lot of randomised control trials in that area yet.
Finally, another question from Slido here. Even if there's a lack of good research evidence for incentive spirometry, do you find that its use in the pre-op period promotes patient engagement in general, which helps with compliance in other aspects of perioperative care?
No, I haven't found that. I think that if you're teaching the patient and you're getting them to do the deep breathing and you get them to use their hands on the side of their chest, and that's enough. The other problem, I think, is that they can use it incorrectly, so that they go like this and, they get into bad habits when they go home with an incentive spirometer. But that's just my own opinion, because as the person who asked the question so rightly said, there's not a lot of evidence.
I think it's a good moment now to bring in our next speaker. And I'm really excited to introduce Rinaoldo Bellomo. Rinaoldo is a professor of intensive care medicine at the Università of Melbourne and works clinically at the Austin Hospital in Melbourne. As you may know, he's a co-director of the incredibly successful Australia-New Zealand Research Centre and a key member of the clinical trials unit. He's also widely acknowledged as one of the most influential critical care researchers globally, who leads the direction of research in critical care. So it's a great honour to have you with us this morning, Rinaoldo. One of Rinaoldo's many research interests is in the area of the amount of oxygen you give to patients who are on mechanical ventilators, both in the critical care environment, but also importantly during surgery. Rinaoldo, welcome. So you've been involved in many of the seminal studies of oxygenation targets, both in ICU and in the perioperative setting. What do you think the key differences are?
There are several key differences. Of course, the oxygenation target and the oxygen delivery in the anesthetic room is for a short period of time. And so logically, people are less concerned about the toxicity of oxygen and more concerned about the toxicity of not giving enough oxygen and the patient experiencing hypoxemia. In the intensive care mechanically ventilated environment where patients have diseased lungs to begin with, intensivists have been more worried about the toxicity of giving too much oxygen rather than the consequences of having some degree of hypoxemia. And so there's been a divergent flow of thinking and a divergent strategy of thinking in research between the intensivist and the anesthetist because of the clearly different clinical situation.
Do you think there's a difference as well, that because the patients that come to the anaesthetic room for elective surgery haven't already got an inflammatory response and tissue injury, which may be important in some of the harms with oxygenation, high oxygenation?
I think that's obviously the biological and physiological point of view of clinicians who would feel that these are normal lungs to begin with. The injury of high levels of oxygen in that setting is going to be clinically minimal, unlikely to play out in any substantive clinical way. And of course, the avoidance of even a whiff of hypoxemia is believed to be important. And with the primacy of the studies of high FiO2 going back 15 years ago, showing a potential benefit on sepsis and wound repair and wound infection, creating an environment where there was a belief that hyperoxemia will be beneficial, then the scene was set for people to believe that giving more oxygen during anesthesia was a priority. And once you create that kind of point of view, you have a thing that is called primacy bias. So, for example, if I tell you that spaghetti tastes better than curry and convince you that that's the case, and I have to displace that particular view from your mind. And because the early trials in the USA and in Spain suggested a potential benefit on wound infection and sepsis, displacing that tradition that giving lots of oxygen is really good for patients is problematic in anesthesia.
And given the more recent trials and the issues you alluded to with some of the meta-analyses and some of the studies from one of the research groups in Italy, where is your feeling that the balance of research is now for hyperoxia during elective surgery?
Look, I think that this is a very difficult question to answer because we do not have the kind of mega trials that are likely to show us whether there is a clinically meaningful impact of giving a particular amount of oxygen or a very high amount of oxygen. I'm sure most people are familiar with a proxy study by the Danes suggesting that irrespective of what you see in the short term, which may be limited in scope, there may be consequences downstream on cancer biology. Whether that's true or not, obviously, is highly controversial and will remain so until people do a study of 30, 40,000 people and follow them up to 5 years after cancer surgery to see if this is real or not. And one might argue that the kind of likely effect in terms of size for a trial will be relatively small, and I think they will be right. But of course, this is a therapy that is given to, I don't know how many millions of people across income-rich countries every year. And so even a minute difference in the, for example, long-term outcome of people having cancer surgery may matter a great deal more than some new discovery of chemotherapeutic agents.
Absolutely. And can we discuss a little bit about the intensity and the duration of hyperoxia? And which do you feel biologically or is most plausible to be the bigger problem? Should we be worried about a short period of extreme hyperoxia, like the pre-oxygenation that tends to be traditional at the beginning of anaesthesia? Or is it sort of the area under the curve, so the total dose of oxygen over time, that's more important?
Yeah, it is unclear. The animal experimentation would suggest that you're right, but there are really no satisfactory sort of studies to allow us to understand which one of these two plays out the most in human beings. And on the logic of it, the area under the curve is most likely to matter beyond the peak or the trough. And I think that's the current view. That's if oxygen is a toxin, the integral under the curve of exposure is likely to be the most important biological determinant of its clinical effects.
Which is important for anaesthetists in particular, because the concerns often about hypoxia are particularly around the time of airway manipulation at the beginning of the end, perhaps lower concentrations during the procedure once stability may be of benefit. It's a real shame that Darshi, who was our next speaker, couldn't join us today, but Rinaoldo has been involved in several of the studies as well, fortunately, of interruptive ventilatory strategies. So I'm going to wonder if you could field some questions along those lines as well for us, Rinaoldo.
I'm supervising Darshi's PhD, so I should be okay.
You should be okay. Excellent. So the field we're talking about now more is FiO2 aside, what is the best ventilatory strategy for patients during elective surgery? And could you give us a little bit of insight into the background of why there's been such a focus on PEEP and tidal volume and recruitment maneuvers, Rinaoldo?
Yeah, and again, it's a really interesting divergent path between anesthesia and intensive care historically. So anesthesia from the 1970s has been wedded to large tidal volumes based on very small studies that suggested that large tidal volumes might affect the degree of atelectasis postoperatively. Again, the usual primacy historical power that this is what enters into the mind of the specialty, 50 years ago, and now you have to displace it. Intensive care, on the other hand, has gone the other way. That's gone towards low tidal volumes, concern about stretch injury. The two of them have kind of existed in parallel. We did some studies only a couple of years ago to see what usual care in Australian anesthesia rooms is. And, the tidal volume, the average tidal volume was 9.8 mils per kilo of predicted body weight across the board. So we thought, oh, wow, that if I did that in intensive care, my colleagues would have me strung up and arrested. And so it was really kind of interesting to see that divergence. And so we thought that it would be of significance to see if it's really true that you need to have large tidal volumes in order to prevent pulmonary complications in patients having major abdominal surgery. And that's how Darshi conducted and designed and executed his trial of basically intensive care style, low tidal volume versus usual care in Australia, as we had established, and we understand that's very common elsewhere, of large tidal volumes. And so we did a study of 1,230 or so patients and randomly allocated them to receive low tidal volume or high tidal volume, if you wish, the intensive care style or the historical anesthesia trial. And we were able to demonstrate that the legend that you need to have large tidal volumes just does not hold water, so to speak.
So no impact of reducing tidal volume on the pulmonary complication incidence?
That's right. We didn't see any effect, but I like the logic to be subverted a bit. No impact of giving large tidal volumes. The historical stance is unjustified. It was created with belief that it would deliver some benefit to the patient. But compared to the low tidal volumes, and I want to emphasize, there are actually no low tidal. You have physiological tidal volumes. That's what I breathe when I take a tidal breath. it's actually physiological tidal volume versus augmented tidal volume, which have been historically delivered to patients having abdominal surgery. So the historical stance that we need large tidal volumes to protect patients from pulmonary complications is invented.
Absolutely. And the PEEP strategy, in your trial, there was equivalent PEEP in the two arms. Do you think
it was equivalent.
Have a good idea of what optimal PEEP is as yet?
That's a really good question. I mean, that's an important question for people having major abdominal surgery. And I'm sure you are aware it was addressed by the Brazilians in the Pro-Obese study in a group that was felt to be particularly at high risk. So these are people that were large people having abdominal surgery allocated to high PEEP versus low PEEP and looking at the effect on post-operative complications. And again, not really able to demonstrate any major effects on clinical outcomes. But again, potentially some subgroups of people might be different, particularly those having laparoscopic surgery, where there is the combination of surgery and abdominal inflation. So there is potential for these patients to be different. And in fact, even in Darsh's study, when you look at the forest plot, you will see that there appeared to be an interaction between the tidal volume and the surgery being laparoscopic or open in favor of low tidal volumes being particularly safer in people having laparoscopic surgery. And indeed, we are just writing a paper at the moment focused on basically about 50% of the population that had laparoscopic surgery, and seeing a signal there, the low tidal volume was associated with a decrease in the risk of post-operative pulmonary complications. Not all patients are equal, not all procedures are equal, and I think we need to do more work, and I think we need to do larger studies. I think these studies of 1,000, 1,200 patients are clearly a lot better than studies we used to do 30, 40 years ago. But I think we really need to go for 30, 40,000 people to have wide generalizability and the ability to identify small effects.
And I just wondered what your feeling was about the sort of interaction between the various potentially injurious factors. We've got the hyperoxia, we've got ventilator-induced barotrauma. Are these likely to be additive, or do you think they're likely to be synergistic? So the patient with a SIRS response already early acute lung injury, and then a ventilatory strategy that isn't protective, as it were.
Yeah, we do not have enough information. You know, the animal models are not very informative. I think, you know, the feeling is that there is synergy, but, you know, really the data does not exist to support a particular point of view at this stage.
Thank you so much for your contribution, Rinaoldo. It seems that there's almost as many questions as we've got answers so far, as is often the case. And as you said, it seems that we need some larger, even larger studies to look for smaller effects in subgroups, particularly because it's such ubiquitous therapy. And as we know that death after surgery
that's right.
is the third common cause.
You know, and in intensive care, we've taken that view, and together with Paul Young in New Zealand, we have embarked upon Mega Rocks. Mega Rocks is a 100 centers, multinational, multicentric study of conservative versus liberal oxygen therapy in mechanically ventilated patients, which is planning to enroll 40,000 people. We are up to about 1,500. We've just begun the journey. We have just got ethics approval to undertake this with waiver of consent in Australia, which is great. We will then be able to start recruiting very fast. And we hope to have Mega Rocks kind of done in about 3 years from now. And within that, as you were suggesting, we will have very large sub-cohorts, like people that have been admitted to intensive care after a cardiac arrest, or like people that have got hypoxemic respiratory failure due to the ARDS, or with people with sepsis, where there may be significant heterogeneity of treatment effect. It may be that the balance between hypoxemia or hyperoxemia, liberal versus conservative oxygen therapy, swings in different directions according to your disease. And it's quite possible that it is so. And so hopefully with 40,000 people, we will have subgroups of somewhere between 5 and 10,000 in different types of conditions that will allow us to explore that.
Excellent. And one just further question from that perspective. Will you be looking also at cognitive function further down the line? Because that's another signal that people are concerned about prolonged hypoxemia. Does it have a subtle effect on cognitive function subsequently, which is one of the concerns for harm?
That is incredibly challenging in an intensive care study. I think in any study, you have an elderly population and you don't have baseline information. It's really tricky. We have obtained some information from ICU Rocks, which was our study of 1,000 patients. And, we didn't really see anything major in one way or the other, but I fully understand that matters. But logistically, we are still unable to deliver it.
Okay, thanks so much, Rinaoldo. I think it's a good moment now to bring in our third and final speaker, Rupert. So, Mark, I think you're going to introduce Rupert.
Well, morning, Rupert, and welcome. For those of you who don't know, Rupert is Professor of Intensive Care Medicine at Queen Mary's University of London. And I think it's fair to say, Rupert, you've got a growing reputation as a British physician for large-scale, multi-centre perioperative and intensive care trials. So welcome, really good to have you here today. Looking forward to the debate between yourself and Rinaoldo, because I think that will be particularly interesting. Rupert, your latest trial, I know many people will have watched the online video that you put on, really just describing the Prism Trial, so the application of CPAP to prevent pneumonia, reintubation and death in abdominal surgery, which was a large multi-centre trial. I wondered if you could just maybe give us some of the headlines that the trial sprang up, and then I just want to talk a little bit in detail about some of the other questions that may have come from it.
Sure. I mean, first of all, it's been very interesting listening to this discussion. One thing that your listener may not be aware of is there's a very large global health trial of perioperative oxygen, high FiO2 versus low FiO2, currently in the pilot phase, and it's being led by the Global Surge Group. And that's really going to tackle that question in lower middle income countries where it matters most, because that's the prime driver of the World Health Organization guidance on surgical site infection, is the concern for that problem in lower middle income country patients. So hopefully we'll, in addition to the Megarox projects and others, we'll have a really robust evidence base on it before too long. But coming back to your actual question, so the Prism trial we put together a while ago now, based on tackling some key issues around the question from evidence from small efficacy trials that perioperative CPAP used in not a treatment way, but in a preventive way in patients at high risk of pulmonary complications could be used to stop them developing respiratory failure and needing to be reintubated. And this is really to directly tackle the issues of pulmonary collapse, atelectasis and so on, that mean that patients who are maybe a bit older, a bit frail, maybe they've got chronic lung disease, are just tipped slightly over the edge into developing respiratory failure or pneumonia just by that small amount of pulmonary dysfunction that they get at the time of anaesthesia and surgery. So at the time, it seemed a very important question to everybody. And although frustratingly, we struggled to persuade major public funders to bite and to support the trial, it was strongly supported not only by funders within our community. In particular, I'd like to thank the Association of Anaesthetists, but also Intersurgical and Bart's charity and one or two others who stuck by the trial. But mainly the local investigators who believed this was such an important question that they invested a huge amount of energy to recruit nearly 5,000 patients to answer it. And I think that's a real tribute to our community, that when we see something that's really important, we really put our energy into solving that problem and answering that question. And what we found was, slightly frustratingly, that a CPAP doesn't prevent respiratory failure, it doesn't prevent reintubation, it doesn't prevent pneumonia. And the main reason for that is shed by the process evaluation that we included in the trial. And what that showed is that when you take an intervention that you're studying in a small team that's very, very focused on which patients you give the intervention to, how you give it, where you give it, and the quality of delivery, and so on, that you can deliver a far more effective preventive treatment. But when you scale that up in a large clinical effectiveness trial to test the real world context of the intervention, you find that you lose some of the value. So your patient selection isn't quite as tight because you're giving it to everybody you think might benefit, not just a small proportion of them. You're delivering it with your routine equipment that you give CPAP for every patient, not special equipment chosen for that purpose. You're not bringing patients into clinic to train them on CPAP because you don't have time to do that. You're not specially training staff to deliver post-operative CPAP because you're just using your routine system to deliver it. And when all of those things come to bear on it, you find that CPAP doesn't work as well. It's not as preventive. And this is really important for us all to grasp, the difference between an efficacy trial telling us, can a treatment work, and an effectiveness trial answering the question, does that treatment work in real world?
Rupert, thanks. I think that's a really interesting point for me. So if I interpret that correctly, do you think there are centres that are familiar with CPAP and have a good patient population that are using it effectively for perioperative or post-operative respiratory complication reduction?
Without any doubt. So what happened was we sent staff around to a selection of hospitals, mostly UK, to look at how they delivered CPAP in the post-operative period. And you found that some centres were delivering patients to the post-anaesthetic recovery unit relatively pain-free, relatively awake, relatively calm and lucid. And they tolerate CPAP really well, surprisingly enough. But when patients come out who are nauseous, in pain, and agitated, maybe enough, they don't tolerate CPAP very well. Now, that's the real world context. If we can improve that real world context, we could probably find a context where CPAP works. But saying that we're just not good enough and we need to do a better job, just saying that doesn't make it happen. And we shouldn't be trying to roll out CPAP into routine care if it doesn't work. Now, it would be great if it did. It would be great if we've got a new solution to a problem that we've been struggling with. But trying to solve a problem with a treatment that doesn't work is not a good way to improve healthcare for our patients.
And there's a couple of things from the trial. I mean, I took part in it as a local investigator, so I'm quite familiar with actually, doing the trial. The paper really talks about 2/3 or so of people having neuraxial blockade, so spinal or epidural anaesthesia, and about a similar proportion going, as you say, to a post-operative HTU type environment. I couldn't see the signals in the paper, but do you think neuraxial blockade actually is a significant co-founder in the trial? As you say, nausea, vomiting, pain, all of those are really difficult things to apply CPAP in.
It's difficult to see. I know there are a lot of very talented anesthesia, analgesia enthusiasts within our community who are dedicated to delivering great patient care. On the unit where I work, where I look after post-operative patients for several days, which is quite a bit longer than a lot of anaesthetists do, and I see them every day, I see people who really struggle to get epidurals working, trained ICU nurses really struggling to make them work consistently for the patient, lots of problems with epidurals needing top-ups, and quite commonly staff overnight resorting to opiates because they can't get the epidurals to work. And that's that classic efficacy versus effectiveness question. So, of course, a very talented regional anaesthetist can get pretty much every patient to have a great epidural if they sit by the bedside for 24 hours a day. Unfortunately, we don't have enough talented consultant regional anaesthetists to do that. So we have to fall back on the real world system to deliver it. So the first question is, does neuraxial blockade actually prevent respiratory complications in and of itself? Well, I think it probably does when it's delivered to the highest possible standard. I absolutely believe that. But as it is delivered in the real world, I'm not so sure. Now, I'm sure there will be listeners here who say, well, in our hospital, we nail it. Well, that's great. But I'm interested in every hospital, and I'm particularly interested in improving care in the hospitals where the quality is at its lowest, rather than improving quality of care in hospitals where it's at its highest. Because we can save a lot more lives in healthcare by improving our weakest hospitals than we can by improving our best hospitals at a global level. So I don't think that the level of regional anaesthesia in the trial reflects anything other than the fact that we selected a high-risk group having major surgery when neuraxial blocks are a common tool. And of course, their randomisation, the balance between treatment groups as well. So I don't think that's mollified our finding.
Thanks, Rupert. I mean, I have to say, I always like pragmatic trials because they are very real world, and I think that is the world we live in. So congratulations for doing that. You make a suggestion in the paper that actually, if you looked at the people going through the trial, they were kind of intermediate to high risk of post-operative pulmonary complications. And you kind of suggest as a beautiful throwaway line at the end that actually it still may be a benefit for very high risk patients. Just talk me through that a little bit more.
It's really important that we as researchers are not seen by talented enthusiasts who deliver really high quality services, that we're killing the goose that laid the golden egg. What I find, and I still find, is a failure to understand the difference between a trial of a new drug with a promising potential benefit that's studied in a small phase 2 trial, and it's maybe shown to work or not to work. But when you scale that drug up to a really high level and give it into routine care because maybe doctors forget to prescribe it, or nurses don't give the full dose because of cannula tissues or all of the millions of other things, the patient refuses to take it and so on, we find that that drug just isn't as effective as we thought it would be. Now, that's a phenomenon that you can see in every area of healthcare and in so many different treatment areas. And that's why Big Pharma may have to produce thousands of molecules or tens of thousands of molecules to get one marketable drug that has real patient benefit. So this isn't a new thing. But to craft specialties like anaesthesia and surgery, we're a little bit unrealistic, I think, that every promising treatment's going to work. And when people like me come along and do a study on them and find they don't, the word negative gets rolled out. It's a negative trial, another negative trial. Well, it was obvious that wasn't going to work, wasn't it? And it's funny that nobody says it's obvious it's not going to work before the trial, but a lot of people say afterwards. There is a frustration that a promising angle, a promising opportunity to improve patient outcomes has been canned by someone like me. That's not what we're trying to do at all. What we're trying to do is show how effective different treatments are and how they should be implemented so that we can improve patient care. Because there's a lot there that relates to just our sheer ability, the capacity, the resources that we've got on the ground, and the way a new treatment might take away resources that we could use in other ways to improve patient care, and whether that is valuable and whether that is appropriate to do that. It's not just money, it's also physical resources like staff or hospital beds or ICU beds and so on. So it's a little bit more subtle, but it's obvious that clinical effectiveness researchers, pragmatic trialists also need to be cognizant of what patients and frontline clinicians need us to be doing in terms of helping them improve patient care as well. So I think it cuts both ways.
Yeah, thank you. I have to say I was definitely a believer before the trial, and I think it's a no worse than. So, it's a really important piece of work, Rupert. Thank you for putting it up there. We have got a question from the audience, actually, which I think probably brings everything together quite nicely. So the question, I think, is if we get everything right, pre-op to post-op, how much could we reduce pulmonary complications, 50 or 75%? I guess the question for me is what is right? I think you've all spoken very eloquently this morning about some of the controversy, but I just wondered if I could open that up, Denny, to our speakers this morning to see what your feelings about what's the perfect package.
A really good and difficult question in a minute, but I think it starts early in the journey. I'm a proponent for the preoperative and the preparation. As with Rupert, I work on a surgical critical care unit, so I see a lot of elective surgical patients. And it's noticeable to the nurses comment to me that the patients who've been to surgery school get out of bed earlier, and they do the breathing exercises, and they ask to get out of bed. So I think patient preparation is important. And I think that's somewhere that we've not focused traditionally and is sometimes harder to implement because those patients are between primary and secondary care. So, we have an opportunity, as Linda alluded to optimize. And I think we have a responsibility to do that because it affects other outcomes, not just pulmonary complications. Intraoperatively, my bias is, as an intensivist, is lung protective ventilation with low FiO2s. But I know that we're not there yet with the data, but I have to admit that to be my bias. And post-operatively, with Mark, I have to say my bias before was that prophylactic CPAP is helpful in some instances. I'd be interested to ask the same question of Optiflow, actually, which has less of the tolerance issues that CPAP may have in a patient who's a little bit agitated, but that'd be a question I'd like to see answered too. And early mobilizing, I think, so, and adequate analgesia. So some questions around, I have the same experience as Rupert in my institution with lots of problems with epidurals. We've pretty much wholeheartedly moved to rectus sheath catheters and local blocks, and I'd like to see a definitive answer as to which is better from an effectiveness perspective. And I know Rupert might be involved in a trial that's about to do that, so a good question to address.
Look, I think there is a lot that we can do to help people in the perioperative period. A lot of that is relatively labor intensive in the end. You have to have physiotherapy, preparation, surgery school, trained and committed people. You have to have good technique with the delivery of CPAP or BiPAP. You have to have people that are committed to optimal analgesia. It's such a complex human undertaking that, my sense is that we need to spend more time in the science of translation, in the science of getting people to work together and put a package of care together. And if we did that as a bundle of care that encompasses all of these interventions in one package versus usual care, I think we would see the sort of things that we trialists would love to see, that is an effectiveness trial that is able to show clinically meaningful differences. But then if we did that, the cynics would say, it's all a Hawthorne effect. And I would say, well, damn it, it's exactly right. And don't we love it?
So I love it when people talk about the Hawthorne effect, Rinaoldo, because if you go and look up, and everybody could look up the Hawthorne effect on Wikipedia, because if you look at what they actually did, it really proves the point. They didn't study a routine factory population of workers. They took the workers out from the shop floor, put them in a different room, in different working conditions, and then said, whoa, look, their performance has changed. The actual real Hawthorne effect proves exactly our point that we might make, Rinaoldo, not the point that the detractors might make. And it's a supreme frustration when people dismiss stuff because of the Hawthorne effect, because I never see it in my clinical research. People are too busy in large clinical effectiveness trials. They're too busy delivering patient care to allow trial observations to change what they do. And I just don't see it. Trial after trial, hundreds of thousands of patients I've recruited into studies, and I see no evidence of a Hawthorne effect. I think in answer to your question, I'd say two things. The first of all, we've got to remember which patients we're choosing here. I mean, Denny brought it right to the very beginning of the pathway, but even before the point where Denny starts the conversation, which patients are we selecting for surgery? Because we've now got very good evidence in the UK that there's at least a 1% growth in surgery activity each year. Now, that may not sound like much, but that's actually huge. And there is a very rapid increase in our propensity to offer older patients over the age of 75 major surgery. And if we carry on at the current trajectory, we're going to have far more frail elderly patients having major surgery in 2030 than we currently do. So when the circumstances are not changing, so we have the same patients and we're changing the treatment to improve outcomes, the patients are getting more high risk, and we need to respond to that. And I think that's the very first thing I would say. And then the second thing is, there's some real questions about implementing what we already know and how we can do that. But if you have that perfect hospital, and I don't work in one, I'm sure you guys do, but I don't. But if you had that perfect hospital, then you could really improve outcomes. But I'm not interested in the perfect hospital, because if you work in one, that's great, that's brilliant. You don't need my help. You don't need my advice. I'm interested in the hospital that's got room for improvement. Because if I can deliver research that shows them how they can improve their patient outcomes, I can have a much bigger impact on the perioperative population.
Yeah, if I can comment as well. I mean, obviously I'm a believer in getting patients fitter before surgery, and certainly if patients, and they are certainly in Australia, older and more frail, I think it takes a bit longer though for those patients to make any difference, in how they're going to cope with the surgery. So if you've only got a couple of weeks beforehand, that's probably not long enough for those older patients. But I'm not sure I totally agree with Rinaoldo in that I think things like surgery school for an hour and a half don't require many resources, really. We use videos as well, and certainly, you have to update them, but it's not a lot of money, and sadly, physios don't cost a lot either in a hospital, and I'm sure that's the same in the UK as Australia, but I don't think that there are a lot of resources beforehand. Intraoperatively, you guys know, more than me about that, and post-op, I think risk assessment is really important, and I'm really interested in the CPAP trial. I did some, in my PhD, I did use some intermittent CPAP post-abdominal surgery and measured PPCs, actually. This was quite a long time ago though, and didn't find a difference actually either, but that was just a small study. But we do tend to use it when patients are becoming hypoxemic and, going down the slippery slide and heading towards a MET or an ICU call, heading to ICU. So the physios in some hospitals can actually institute intermittent CPAP. And we have actually found that does help, but that's just what we think. It's not really shown up, as you say, in a trial, but more targeted rather than prophylactic. And I agree, implementation is the way to go. It is our future. Our funders here have suddenly found, learnt that they have to fund things that are going to be workable in real world. So totally agree with the implementation trials. And it would be great if we could have a system like Rinaoldo says, when you can have so many patients, if we could do it in Australia, New Zealand and the UK in a perioperative sense, that would be really great to get the numbers up so that we can actually make some decisions from pre-operative management.
That's almost perfect timing, because we're just coming to the last 30 seconds or so of our session. So I'd like to thank all the speakers for a fantastic session today. It's been a great pleasure to speak to you all, and thank you for your contribution.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.